Remember that? That means the meeting is called to order. Okay, let us start off with Amelia's housekeeping item.
So good morning and thank you for joining us for our business meeting. This meeting is being recorded. The documents which will be discussed here today are available on the event calendar on our website, which is wmc.wa.gov. I am Amelia Boyd and I am the program manager for the Medical Commission. Kayla Bryson and I are the organizers for this meeting. Panelists, please be sure to mute yourself if you are not speaking. Attendees are automatically muted and will remain throughout the meeting unless they are unmuted. Please note that anything posted to the chat or questions section is considered public record. We will take public comment at this meeting. It is item 6 on the agenda. Once we get to that item, Mr. Malden will read a script and will then ask for public comment. If you would like to comment during that time, please use the raise your hand function or simply speak up if you are calling in. Our time for public comment is limited and each speaker is likely to only have about 2 minutes to speak. You can also put your question in the question section. If you have any other questions or comments, please send them to me at amelia.boyd@wmc.wa.gov. And with that, I will hand it over to Mr. Malden for his chair report.
Thank you, Amelia. I just have a couple of things. You may recall that Dr. Roberts spearheaded the panel swap concept to see or determine if we had differences of approach, and with the thought that we want to make sure that there's a consistency between the two panels in reviewing cases and coming to logical conclusions. Logical conclusions is a broad term, but I think a good one. So it was decided to have a midterm meaning about half of the commissioners had made the panel swap. So we did a survey, got about 10 responses. I shouldn't say about, I think exactly 10 responses. A couple of folks who were involved in the panel swap are no longer on the commission, so pretty good response. I'm going to give just a brief summary of the 10 comments that we received. And I've also asked Rick Klein to de-identify all of the responses in detail, and I'll send those out in an email later on today. But generally, I think the commenters thought that the experience was worthwhile. There was a thought that there was not a significant difference in process or outcome. More specifically, comments thought that perhaps panel A was a little more formal than panel B. Panel A's presentations seemed to be a bit more long and detail oriented. Panel B presentations seem to be more summary oriented. One of the noted differences is in process. Panel A does not allow A3s to be placed on the consent agenda, whereas Panel B allows A3 closures to be on the consent agenda. Panel B, it should be noted, oftentimes takes cases off of the consent agenda. Not necessarily a requirement, but oftentimes it does occur. So those were the generalized comments. I don't know if anybody else wants to make a comment about their observations of making the panel swap.
So this is Bob, and I'll just comment, and I emailed this to you, John. One other process difference is that Panel A does STIDs and orders as a first order of business, where Panel B, I believe, does those after lunch. That's been the case in all my years on the commission. I don't see that as an issue, just an observation. The work still gets done both ways.
Yeah, I think that Panel B oftentimes uses the orders as a filler when we're waiting for call-ins or waiting for attorneys to arrive at Panel B. And then whatever's left over gets done after lunch. So a little bit different. Any other comments about the swap from those who participated? Scott?
Thank you. I think part of the intent in the beginning wasn't so much focused on process as it was to make sure that we're giving everybody a fair shake. We're considering all the evidence and we're reaching the right conclusion. And the one thing that was glaringly obvious to me is that everybody on both panels wanted to get to the truth. They wanted to be fair-handed. They wanted to protect the public. And in my opinion, I keep a lookout for groupthink. I keep a lookout for other things that can go wrong in deliberative bodies. And I'm proud to say, participating on both panels, each panel, I think the outcome was high quality. The deliberations were intense. I don't see any issues with social problems where there were no alliances. Individuals could disagree vociferously on one case and agree on the next. In my mind, I'm an N of one, but in my mind, I don't think that people are getting different treatment based on which panel they're in. I think this was a success. Thank you.
Thanks for those observations, Scott. I'm not sure if I mentioned
John?
that, but I thought that outcomes were something that were fairly consistent. Yes, Dr. Roberts?
We had a really fascinating experiment yesterday in which we changed the panel chairs so that panel A's chair ran panel B and vice versa. Could we possibly get the chairs to comment on that? Because I found that very interesting.
Dr. Chung, Dr. Jagger?
Yeah, so I think as chair, I didn't feel like there was any difference in terms of how I was able to run the meetings. I think my observation of the different panels is that there was a comment earlier made that perhaps panel A was more informal than panel B, and actually my experience was the opposite. Also, I think it just reaffirmed my belief that I already had, that both panels were effective. Both panels were filled with extremely professional and very nice individuals. Also, very, everybody had the same depth of analysis and thought when giving thought to each of the cases that we discussed. I also thought that the culture, if you will, of the two were not too different. There was a sort of an equal level of a sense of humor that was used during the meetings, a sense of humor that was tolerated during the meetings. And so I think I enjoyed chairing panel B almost as much as I enjoyed chairing panel A. But I certainly felt very welcome. I didn't feel like I was doing anything that was unusual or anything like that. So I think my overall sense of this project was that it was very successful. It was very reaffirming. It did point out a few differences that I think we can all be aware of and work on, but none of those I think lead to significant changes or variation in potential outcomes of the case reviews that would be attributable only to the fact that one goes to panel A and the other goes to one, or panel A or B. So thank you.
Thank you, Dr. Chung.
Could I make a comment, John?
Yes.
Or should I
please.
wait till Dr. yeah, I can wait.
Dr. Jagger, let's have Dr. Jagger first, if you don't mind, and then we'll.
Yeah,
Then Dr. Yu.
please. Sorry.
Good morning. I don't have anything real different to add to the conversation. Overall, I thought that the general functioning of both panels was very similar in their overall goal of protecting the public and making sure that they had enough information to comfortably make a decision about the cases as they came up. And it was really it was enjoyable to get to meet the different commissioners in that setting and get to have a better sense of how they think and work. And overall, I don't think I had anything significant to remark upon that hasn't already been commented upon by other panel members.
Thank you, Dr. Jagger. Dr. Yu?
Yes, thank you. I don't know if I am the only commissioner that haven't gone to this shifting, this music chair. So I haven't had opportunity to go to panel B to observe, how they discuss cases. So I wonder will I get opportunity at all? So
Absolutely. So there
yeah,
should
okay.
be, I'm not
There's
sure.
another one.
Probably about eight
Okay.
or I don't know, 7 or 8 commissioners who have not made the swap yet.
Okay, because I would love to observe panel B, but I want to make a very quick comment. That is, in terms of how long does it take, how much detail give out, the difference between two panels. From my perspective as a public member, a non-medical profession, I felt there is a balance. I feel very benefited for discussions that gave out some details, including, medical terms and all that things, because the discussion is for people to make informed decision to vote on the cases. And in order to have a, good decision, you needed to know it. They listen carefully and give enough information for people to make decisions. So that's all I'm saying.
Well, the good thing is that the public members can ask questions and rely on some pretty heavy duty expertise in the room. So.
Right. That's like going to doctor's office when you're not medical, you don't have a medical background sometimes, and you don't even know what question to ask. So, that I feel sometimes the same situation. Yeah, we try to ask more questions that sometimes that, essential information was critical for us to learn. No. So.
Okay, thank you very much. Any other comments? Hearing none, we'll move on. Again,
I just
I'm sorry. Yes, Dr. Roberts.
Response to you. I did not perceive a significant difference in content. That doesn't mean one isn't longer and one isn't shorter. The information that was needed to explain public matters and the information that was needed to understand the case, I think was virtually identical in between the two panels. Additional information may have been added by one panel or the other, but I didn't find anything that was different as it relates to the facts that are necessary to make a decision about the case between what I observed in panel A and what I observed in panel B.
And
yeah, that's why I'm very interested in go to panel B to learn about what you guys do.
And I agree with that. I didn't want to suggest that there was a lack of information on either panel. I think there was sufficient information in all presentations by both panels to make the right decision. So thank you for that observation. Anyone else? Okay, we'll move on. As you know, the legislature started this week. Part of that process for the commission is a legislative committee. I was able to attend the first meeting, which was the Wednesday before the legislature began its session. Unfortunately, I missed this last Wednesday's meeting due to a power outage most of the day on Wednesday. So I'm going to just mention a few things that were mentioned during the first legislative meeting, and then ask anyone who went to or participated in the session this last Wednesday to add whatever was discussed. There were 5 bills mentioned during the first meeting. One of the bills introduced was to limit executive orders, and particularly came out of the COVID response. The bill specifically tries to limit the scope and time, and also requires a 2/3 majority to approve the executive order. Not sure where that one's going to go, but that's on the table. There were 2 House bills and 2 Senate bills. One of the House bills, 1060, got my glasses on, 3, dealt with behavioral health certificate renewals. House Bill 1008, title is prohibit abortion on the basis of Down's syndrome. Senate Bill 5018 is to redefine acupuncture injections and allowing lidocaine, oxygen, and epinephrine use by acupuncturists. Senate Bill 1043 deals with audiology, speech, language, and interstate compact. So those are the 5 issues we talked about at the first legislative meeting. Anybody that participated this last Wednesday, can you provide an update of what was discussed? Dr. Roberts, were you participating?
I was unable to participate this past Wednesday, but there is a bill that was discussed. It's a Senate bill, and it is a bill which would allow naturopaths and certain other what we would consider practitioners that are similar to ourselves, that haven't had the training that we have. This bill would allow them to prescribe category 2 through 5 prescriptions, and that includes tramadol, a variety of benzodiazepines, and I think, as Dr. Terman said, if you look at that bill, it's a really important bill, because as you look at that bill, it can do nothing but add to the opioid crisis. It takes people who have not had significant training in terms of these medications, the physiology that's involved with it, and who haven't had training in data management, and it will allow them to prescribe medications that can significantly contribute to the opioid crisis. So my recommendation would be for commissioners, I wish I had the number of that bill, and perhaps that can be supplied to us, but if commissioners can talk to their representatives in the Senate and let them know their opinion on this bill, that would be very helpful.
Thank you. I think what Dr. Terman had mentioned was it's Schedule 3 through 5. So I assume that is that.
That's what I said, but that's correct.
Yeah.
Senate 508.
Okay.
Yeah, thank you.
I wrote my senator yesterday.
Thank you.
Thank you. Melanie?
Yes, there's a couple of other bills. There's a bill, House Bill 1129, to create a limited license to IMGs. This is one that we've been working on for quite some time. There is another bill, House Bill 1141, expands the death with dignity to include physician assistants and ARMPs. We don't have any a stance on that currently. And then House Bill 1152 creates a work group and new rules to address health equity and public health inadequacies to create public health districts. I don't have a lot of information on that, but I think that will be interesting. And lastly, I don't know anything about this, but it's Senate Bill 5124, which would create a new credential under the Board of Naturopathy for hydrotherapists, which has something to do with your colon. I'm not sure what that is, but it doesn't sound comfortable.
And this is Heather.
Who's the number that's?
This is Heather. I just wanted to remind the commissioners that there is a prohibition on commissioners lobbying in your official capacity. You can provide information to legislators. In your individual capacity, you obviously can do what any other citizen can do, but just to be aware that if you are discussing a bill or any sort of initiative with a elected official, just to make sure you are not lobbying on behalf of the commission, that you are doing it as yourself as a private citizen, and just to make that clear.
Thank you, Heather, for that caution. Dr. Murphy, did you already mention what you were going to mention when you raised your hand?
Yes, regarding Senate Bill 5088, I wrote my senator as a private citizen and physician.
Just so that you know, we also provide commission responses as a commission to let folks know the impact that it would have, and sometimes we testify. So we do that in an official capacity, and we can do that in an official capacity.
Thank you. Any other comments about legislative issues? Okay, I'm going to move on to an item that was raised by Dr. Lewis. I thought she had a great idea with regard to the current status of the COVID vaccination process. In the news, all I hear about is the difficulty of getting the vaccine in arms and not having enough people to perform the work or places to do it. And I know Melanie has some comments about this as well, but I'd like to ask Charlotte just to briefly talk about her thought process of forming a pool of physicians who may want to volunteer in the vaccination process.
I don't really have much to say. I just thought it would be a good opportunity to see whether or not we could utilize physicians who were interested in volunteering to do this in some capacity, coordinated with whatever advice we could get from DOH.
So the thought, as I recall from your note, Charlotte, was to perhaps put a pool together, or at least use the commission to promote or advertise, perhaps. The thought that docs can volunteer and enter the DOH pool of individuals available to provide vaccinations. And I know, Melanie, you mentioned in an email to me that DOH has already put together a volunteer list of retired individuals, not necessarily physicians, however. Can you comment on that?
Yes, DOH is working with all of the providers who can give vaccines, and also to waive some rules so that other types of providers can provide vaccines. There's been some issues that the department has run into with having retired practitioners come back and do vaccines. For example, nurses have to have a refresher course if they've been out of practice for a certain period of time. So there is a huge work group within the department looking at bringing retired practitioners back on the rolls to just give vaccines. I didn't find anything that would prohibit a retired physician from giving a vaccine, but there are other providers who have to have certain kinds of certifications and training. So they're working at it as a department. They have a copious plan for rolling out vaccines. We have put it on our Facebook page. There are phases for folks to determine when you can get a vaccine. I think I'm in the last phase before the end of the vaccine, but anyways, so there is a plan, and I can certainly provide more information or get more information, but there are some retired groups that have to go through some sort of refresher course, and that's is being discussed pretty much. I think it's today, actually. I'm missing that meeting because of this meeting.
Yeah, I think there's been.
You know,
go ahead.
This is Claire. So at Kaiser, we're bringing in docs to do this too. I would say one thing, that the physicians getting a refresher course doesn't hurt at all. Docs don't spend a lot of their time giving shots, and there are some standards that need to be met. It isn't just that simple. So I think as a physician, when we've gotten into doing this, I've always done the courses with the nurses, and it's helpful just to remember all the steps. And Melanie, do you know where the state is doing it?
I'm sorry, what do you mean by where?
So they're talking about setting this up, and also Charlotte, like what facilities? Or are you just talking about having names on this?
Just names on a list. I believe
that could go to anywhere.
Well, I believe the state is also looking at distribution areas, and they have a plan on that as well. I don't know what that is currently, but I can certainly look into it and provide that to y'all if you're interested.
If I can interject, this is Teresa. The Medical Reserve Corps is the group that's coordinating through each health district, through each county, and through the Department of Health, if I remember correctly. So if you look up Medical Reserve Corps, it'll actually bring you to the Washington State Department of Health website, as well as the specific county. For us, we have in Eastern Washington through the Spokane Regional Health District. I see that Mason County has one, King County has one, Snohomish has one. And what they're doing is they're taking doctors, physician assistant nurses, nurse practitioners, dentists, and dental hygienists to give vaccines. So look for your local Medical Reserve Corps, and that's a good place to be able to help give vaccines. I know Dr. Roberts was talking about it yesterday. The other good thing about this is that if you're volunteering to give a vaccine, you get a vaccine.
That's a good incentive. Any other comments? Okay, let's move on to the consent agenda. 2 items on the consent agenda are approval of the November 13th, 2020 business meeting minutes, as well as the business meeting agenda for today. Any comments? Okay.
Move
Do we
to
have a
approve.
second? Do we have a second? Is a second? All in favor? Say aye. Raise your hand.
Aye.
Opposed? Motion carried. Item 5.0, old business. Committee reports are found on page 13, I should say committee work group reports. Are there any additions or late ideas on any of the committees that need to be mentioned? Okay. Next item is rulemaking. Amelia, do you have rulemaking highlights?
So aside from what is on the report, we had our first workshop on Wednesday for the PA rulemaking, and it went very well, I think. It was pretty quick. And we will have another one probably either in March or April, and we're going to try and wrap that rulemaking up around that time. So, but that's all that's new.
Okay, thank you. Lists and labels. Heather, I think there are 2 requests on the lists and labels agenda today. Do you have comments?
Yeah, so the first is the University of Washington, and I believe that they do meet the educational organization definition, so I would recommend approval on that. The second is Seattle King County Health Department. And their TB program is asking for lists and labels, saying they're a professional association. I did have one question on this one. They're, not what is typically a professional association, but also I'm not sure they should have even been given this form because they aren't using it for commercial purposes, and that's usually what this form is for. So that may be something in the process that we need to look at. I can tell you that the Osteo Board did approve Seattle King County Health Department.
Heather, this is
Yep.
Alden. I'm not sure what we need to do to help them move this along, but we need to help them move this along. This is important work.
Yep.
What do you
I
see?
don't understand why they weren't just given, at least Seattle King County wasn't just given this information without having to go through this hoop. So, I think I would recommend approval on both.
Okay. So we have a motion to authorize the University of Washington to have lists and labels. Second,
So moved.
all in favor say aye or raise your hand.
Aye.
Aye.
Opposed? Motion carries. Second item, Seattle King County TB Control Program. All in favor say aye. Raise your hand.
Aye.
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 Opposed? Motion carries. I guess I forgot a step there, but we got to the right decision. Okay, next item is public comment. I'm sorry. Somebody have something to say? Okay. We will now begin the portion of the business meeting to take public comment. The purpose is to allow members of the public to directly address the commission on issues of public concern. Please refrain from providing comments on pending or open investigations or disciplinary cases. We will not be answering questions or responding. Staff will be available after the meeting to answer your questions. Please understand that although the time period for comment during the business meeting is limited, the public can attend and provide comment at commission committee meetings. The public can also contact staff during normal business hours. We welcome written comments as well. Each commenter will have 2 minutes to speak. When you comment, please state your name and who you represent. Would you like to comment at this time?
So there are no hands raised and there are no questions in the question box.
Thank you for that. This concludes the public comment portion of the meeting. I want to thank you for your not participating. Again, you may provide written comments at any time. Dr. Domino, you are up next for the policy committee report.
Good morning, everybody. We have a consent agenda item from the policy committee that we approved. The consent agenda is being used for items that are considered routine policy committee matters and are approved by a single motion without separate discussion. You see this on your screen. It says page 2 out of 3 at the bottom of the 4 items that are interpretive statements. They've been recently included in a recent update of Physician Chapter 246-919. And so our committee had approved this consent agenda. Is there any discussion? No. Can I have a second for this? Great. All in favor? Raise your hand.
Aye.
Aye.
Or say aye. Great. All right. The second matter is one that we've seen before, and we brought it back for some minor changes. And this is one, it's listed on page 31. It's on your screen. believe, or at least we see what's on that. If we could have it on the screen, it would be great, but if not, we see what it's in your packet. And it's called Direct Communication of Time Critical Patient Medical Information Between Healthcare Practitioners. This one was discussed before, and we had, as a result of the discussion, realized that it was the word physician was included, yet our commission does have PAs on it, and they are healthcare practitioners, and there may also be other healthcare practitioners, such as advanced practice nurses, who you need to discuss patient information with. And so the document was changed in order to provide change L, the physician, to healthcare practitioners, and that's listed there. The only, I think, change from what was in your packet is listed on the page 2 of 3, which must be page 32 or so, and that 33, sorry, maybe 34, and that's under guideline under number 2, and it says, thanks for putting that up. If we turn to the next page for guideline, findings that are discrepant, the word was changed with discordant. And otherwise, we had approved this document in the policy committee. Mike, do you have any other comments about it?
No, I don't. That's it.
Okay. Is there any discussion of this?
I just want to give committee a applause for the work you've done on this documentation. It's very good.
Well, the credit goes to Mike Farrell. He's done a great job in doing this, but thank you. Can I have a second a motion to approve this document?
Actually, I'm sorry, Jimmy Anderson here. I'm a little late to the party on this one. But Teresa, do you have any thoughts about this as far as the wording, as far as practitioner, clinician, et cetera, regarding PAs and Ps?
Now, I think that putting clinician on there, or practitioner, excuse me, on there is fine. I think it's a general term, and especially, Jim, since there's some talk about changing the physician assistant name, I think it's fine.
Good. Okay, great. Thanks. Me too. I just wanted to make sure you were on board as well. That sounds good. Thank you.
Yeah.
Hey, Karen, just as a point of information, you don't need a second for the policy committee stuff because the committee has already forwarded it, and that constitutes a second.
Okay, thank you for the reminder. So can we vote on this? All in favor? Raise your hand or say, anyone opposed? Okay. The next document, or actually in my file it was the next one, but it's listed on page 31, is called Commuting Test Results to Patients. This one has also, we had seen this before with changes made the last time and approved by the committee, but it came back and we made one additional change, which is, if you scroll down on this, whoever has this, Mike, or whoever has guidelines under number 3B, we made a change there, just from the practitioner should document in the record, just to say the medical record should reflect who made the communication, how the communication was made, and whether the communication, when the communication was made. The committee felt that sometimes the practitioner may not be the one actually documenting, particularly in outpatient care. It may be a nurse or it may be a scribe who's doing that. And that was the only change we had made to this document, and we approved it with that change. Is there any discussion about this? Not hearing any discussion. We want to put this up to
Doctor, could I make comments?
Sure.
First, I saw the subtle difference between the wording that highlighted in yellow, and if I understand correctly, maybe just to clarify, you mean when this changes to medical records should reflect. That means that broader, the practitioners that involve the care, like nurses or some others, not just a physician. Is that what is try to reflect on that?
Yes.
So that means sometimes maybe not physician or PA, they write down, but someone else will have to be documented.
Well, an example might be if you go to your ophthalmologist, frequently they have a scribe. That is, and they do the exam, but they don't document them personally. So we felt that while the physician doesn't document personally, there is someone there to document for the physician. And under that was why that change was made.
Okay. Well, if the physician is a treating physician who lead the care team, will the physician have responsibility to make sure that this is indeed documented by someone who, who is supposed to document?
I mean, our presumption is that is yes. It is under the physician's supervision, but they may not be the one who's physically typing something into a record.
Okay.
Just to dovetail off what you said, Youngie, my dream is to one day move to where we're not just saying physician because.
Well, I'm sorry. I'm sorry.
That's okay.
I think the word physician was said that. This particularly said the practitioner. We tried to get rid of all the physician out of this stuff.
Thank you very much. I appreciate that. Thank you.
Yeah, to be sensitive, because there are lots of folks, including besides PAs, who are also providing health care.
And also, I think one of the things I think about is, the two primary constituent groups of the commission are PAs and MDs. So thank you.
I don't know if people have any other comments about this. No. Okay. Well, we recommended approval with this change. I'd like to take a vote. How many want to approve this document as listed? And how many? Is there anyone who's against approving this? No. Okay. Thank you very much. The last document called Practitioners, again, it's Practitioners Exhibiting Disruptive Behavior. This document, Mike had tried to, had updated. The policy committee had extensive discussion over this, including Dr. Bundy, who provided some insight into disruptive physician and PAs and practitioners. So what happened is we tabled this for further work, and we'll bring it back to you after we reconsider the document. If you do have any questions about, or I should say, comments about it, it might be good to relay those to Mike Farrell. In particular, I want to point out there was a list of particular actions that were examples of disruptive behavior, and we removed those things because we felt the definitions that Mike had included were sufficient and broad. And there was also some terminology regarding some psychological disorders that we also recommended approving, and so please read through this and provide any suggestions to Mike. Okay, that's all the policy committee report.
Can I make just one quick comment on that, Karen? I noticed it says everywhere Medical Quality Assurance Commission, so all those should be changed to Washington Medical Commission.
Yeah, thank you. And Dr. Small, you might wish to look at the Axis 1 and 3 items. I don't have this right in front of me, but there is some dated psychiatric language in there that we recommend moving. It's later in the document. I get out the document. It's listed on mine as page 3 of 3. It begins, moreover, disruptive behavior may be a sign of illness or conditions that affect clinical performance. So I'm sure we would really appreciate your suggestions about that.
Sure, I'll take a look at that. Thanks.
And this is Jim once again. I wanted to say that I think this is a great document. I mean, it's got a really nice, it's hard to do like a laundry list of all the disruptive behaviors, but it's got a nice list of some of the most common ones. So I'm really proud of this document. Great work. Thank you.
Yes, Dr. Yu.
Yes, there's one conduct listed under this abrupt behavior. It's about sexual act in nature. I wonder, how do we separate this with abrupt behavior versus actually a sexual misconduct, if we put in there?
I'm not sure where you're discussing this. Is this under the examples of disruptive behavior? We had recommended removing that section.
Oh, okay. I'm sorry.
But please again, if we'll this is a work in progress, and it will have more work. So if you do have comments about this, please do provide them to Mike Farrell. Okay. Any other comments, suggestions concerning this document?
Right. Yeah, this is Mike. If I could ask a question.
Sure.
Jim Anderson, were you saying that you like these bullet points, these very specific examples?
Well, I think that in policy, my experience over the years, as far as trying to create policy in professional associations or whatever, is there's going to move away from quote laundry lists. But I do think that it's important to have some examples, and so this doesn't limit the behavior to this list. This is saying these are some examples of, and so I think that's a very appropriate way to put it. And this is a nice description of some of a very broad array of things that people can do that would be considered disruptive, but it's not limited to. So I think it's nicely worded. I do think still it's the quote laundry list thing can be perilous, but I think this is a nicely worded way to list some and say, but this is not all of them.
Okay, the committee last night, the consensus was to get rid of this list. So if anybody has strong feelings about that, let me know.
Mr. Rogers, you had something to say, did you?
Just very briefly, I was going to say that there was some discussion about it. Some of the bullet points, anytime we make a laundry list, we get into the intricacies and debating the merits of each one. I mean, some of them mention anything that could cast the hospital or another provider in a bad light, which questions, well, then can you even discuss iatrogenic injuries at all without committing disruptive behavior? And then, well, we publicize discipline. Are we not engaging in the same disruptive behavior by the nature of our very committee? So I'd encourage everybody to attend the policy committee meeting and let's have a spirited debate and come up with the best document we can.
And I would also say, I apologize. I'm on the policy committee. I was not there yesterday because of not feeling well, but it's sort of bogus to come in the next day and comment. So thanks a lot.
Yes, Mr. Molden.
I was just going to mention that the language in red just above the examples is a joint commission definition of disruptive behavior. And I think yesterday in our discussion thought that language provided specificity and a broad approach to disruptive behavior, and I thought that was sufficient rather than providing specific examples.
Thank you. That was our feeling at the committee. But again, we like everyone's input, so please do provide it. Thank you for the excellent discussion. Hey, John.
Thank you, Dr. Domino. Let's move on to member reports. This is a free-for-all, so feel free to speak up. Sounds like there are no reports from the commission members.
John, can I,
Maybe I just feel.
Yep. Mr. Anderson?
Can a question be part of a report?
I think so.
So, you know, with the new changes to the PA rules, and they're not without a nuance as far as which take place in June, I think, as far as how PAs and, you know, the regulations regarding PAs. I've been thinking recently it would be great to have maybe some kind of a lunch and learn session about that. So I'm going to follow up with Jimmy, but I do think that these are significant changes which could impact all of us in some ways. And I think it's important we all come out of this whole thing having some understanding of it, because I know PAs at the highest levels who are like, what? I have no idea what these are. So I'm hoping we can, maybe I'll follow up with Jimmy about that.
Yeah, and Jim, John, if you don't mind, I'll add on to Jim. I think it would be important too that maybe we could make that available for outside folks, because there might be some previous osteopathic PAs that might be interested in coming to that and learning about that as well.
Okay, I don't know if Jimmy's listening in or not, but perhaps staff can bring that to her attention.
Jimmy says, sorry, she says, yes, there will be an educational component to the implementation. She is in the process of working on that, so.
Okay, thank you.
And our lunch and learns are always open to the public, so.
Thank you. Dr. Yu?
Yes, the Washington Patient Safety Coalition is organizing a annual conference in October, and their conference going to focus on this time on health equity and disparity, emphasizing on that. I just thought that, you know, if a commission could appear, you know, do some presentation there, and because you all have lots of knowledge about how to care for patients and address this critical issue and in terms of patient safety. So if just commission is interested in just keeping an eye open and ears for the coming events.
I think we have a committee work group that's associated with that topic, but I'm not sure where the work is at this point in time.
Yeah, I just think a commission would have unique position to present, you know, from the perspective of medical care, setting and how they address this issue.
Okay, thank you. Are there other, Teresa?
I just want to let everybody know, if it's hard to get a hold of me for some reason, I have once again been detailed to the COVID team through Employee Health at the VA here in Spokane. So I'll be doing some dermatology, but my schedule is pretty much freed open so that I can go and give injections to our veterans starting the last week of January. So that may be taking up a little extra time, and I may not be as available as I normally would. So if you need to get a hold of me, email or text me is always the best way.
Thank you. Other comments? Dr. Chung?
Thank you. I believe Mr. Rogers had his hand up before I did, so if you want to go to him first.
Yeah, I'm sorry, I can't see everybody on my screen, so I don't mean to slight anyone, but go ahead.
Please go ahead, Dr. Chung.
Thank you. I just wanted to call out yesterday's Lunch and Learn, that it was extremely not only interesting, but very important, both in the work that we do and probably in the lives that we live. And I did want to, without rehashing the details of the session, perhaps emphasize that the lessons learned, while valuable to us as individuals, are valuable to us as an organization. And I sort of left the
session feeling like we have not had enough time as a commission, as an organization, to really talk about those issues as a group. I think we learned a lot in terms of how it applies to each of us as individuals, but not very intentionally and strategically thinking about what we can do, what needs to be done, and what we can do as an organization. I know Melanie and her staff are working on a lot of these changes, but I believe that it would be worth our while to have the commission perhaps take some time thinking about how it applies to the organization as a whole, and what kind of things that we can do and things we need to think about to apply those principles.
Jimmy, this is Jim Anderson, and I totally agree. And I was sick yesterday and missed one of the things I wanted to see the most ever, and I'm really sorry about that. I would say that earlier on we tried to fly a health equity work group or something on the commission. That we didn't really ended up just sort of drifting and not really knowing what we were going to do, so we stopped it. I'm not saying it needs to be resurrected, but I do think maybe, I mean, this, the impact of systemic racism and implicit bias, these are such important issues that maybe once again, maybe the commission could consider looking at floating some sort of like a work group between staff and commissioners, because this topic could not be more timely. Thank you.
Yeah, I'm not pointing out that, trying to point out that we have problems. I'm just saying that if we don't address it at this time of age, at this day and age, that, we really would be falling behind the times.
I think it's important that we recognize that as a socially responsible organization, obviously, and I think there's some good work already going on in that regard.
Is this something that can be brought to policy?
I'm sorry, I missed that, Dr. Roberts.
Is this something that could be brought to the policy committee? An initial thing?
We already have. Well, we have 2 work groups. We have a health equity work group that is already underway, looking at our policies inwardly and outwardly, and we have a health disparities work group, and that one hasn't met yet, but we are fixing to meet within the next month or so. So we are addressing these through work groups.
But that would get it to a majority of commissioners if your work product from there came to the policy committee and we could adopt it as a policy for the commission.
Right, we haven't come to that point. Right now in the health equity work group, we're looking at our current policies to see whether or not they introduce bias, and if the policies that we currently have on the books need to be rewritten or looked at closely with that eye. And once that committee comes up with a list of policies or guidelines or procedures that are already on the books that may have implicit bias baked into them, then they will bring those to the policy committee to look at maybe redrafting. So they're in that stage right now of reviewing the current policies.
Also, Melanie, I want to just say that I don't know if you've had enough kudos, but there's a tremendous anti-racism statement which the commission has posted online, and I think that what I would hope is that statement would help to sort of guide some policies as far as where to go next, because I think it's an amazing policy. I'm not sure who wrote it, but I think it's one of the best I've seen. So thank you.
Thank you.
Mr. Rogers, I think you were next.
This is a timely comment with the discussion, especially because this is a forward-facing meeting to the public. I just wanted to heap some praise onto our staff and just acknowledge that with these diversity issues and implicit bias, our commission was called out specifically in the Federation of State Medical Board journals. There was an article about how we are leading the way in addressing implicit bias. Melanie De Leon had a pull quote in the article, so I just want to praise the staff and the commission this is important, and we're being recognized as leading in addressing these issues.
That's a great comment. I find since I've been on the commission that the Washington Commission seems to be on the forefront of issues before anybody else is there. So that's great staff work, I think.
John, could I ask?
Teresa Schimmels and then Dr. Yu, please.
Okay.
Oh, Teresa's waved me off. So Dr. Yu?
Yeah, it's just a clarification.
Okay.
I see I'm me on a health equity work group. I haven't participated in a meeting yet. I'm looking forward to working with you all. But my question is, what is the different focus between health equity work group versus health disparity work group?
I can answer that.
Yeah, that would be great.
The health equity work group is, we are looking at our own processes and procedures, policies, guidelines, interpretive statements that the commission publishes to see whether or not it introduces implicit bias and to scrub those. The health disparities work group, we are looking at a different set. We are looking at whether there are things that are marginalizing groups of individuals out in the environment. For example, we are looking, the first issue that we're looking at is maternal mortality rates and why the rates are so high for African American women. So we're looking at what can the commission do to mitigate some of those health disparities. Can we educate practitioners? Can we educate patients? Those kinds of things. So it's sort of different.
Yeah, great. Really appreciate it. That helps.
Thank you.
Claire, I think I saw your hand at the little corner of my screen. You might be muted.
Well, maybe John, as we wait quickly, this is Jim. You know, I mean, people often say that health disparities, health equity, what's the difference? And the, you know, some of the literature says health equity talks about social justice and health, about some people are disadvantaged versus others. And health disparities is more looks at metrics we use to measure the difference between various groups. So health disparities is sort of a measure that informs our understanding about health equity. That's my understanding.
Thank you.
Thanks. I think I figured out how to unmute me. Did I?
You did.
Can you hear me?
Yes.
Okay. I wanted to say something about yesterday and about implicit bias in this commission. And it's a bit of a story about one of the cases that I talked to several women who had been on the commission before me for many years, and they were upset about a case of sexual misconduct that was not pursued. And this particular sexual predator continued, and it came up again with us, with the commission. And what was interesting about it related to yesterday's meeting is that this physician targeted drug addicts because they were people that he could manipulate, and bias would go against them if we got to a hearing or to a commission. So he actually used implicit bias as part of how he hid over many years of being a sexual predator. And I think that we finally are sanctioning him and getting on top of this, but to me it showed an evolution of this commission in its awareness around implicit bias. And I was going to say one of the things that really helps is being exposed to many people. The diversity of the commission, I think, helps us address implicit bias also. It changes our thinking and how we see things. So that's what I think.
Thank you, Dr. Trescott. Other comments? Okay, let's move on to staff member reports. The written reports are found on, or I guess begin on page 39. Are there any additions?
I have a
Additional
couple.
thoughts? Okay, Melanie, thank you.
Okay, I always have a couple of sort of, late breaking things. So the Department of Health has updated all of their card readers on the building. So the badge that you currently have will not get you into the building. And so we are all being issued new badges. We have asked, Kayla has sent out a request for the commissioners to send her a picture. She has received photos from Doctors Chung, Curry, Curtis, Domino, Flugstedt, Mr. Malden, Dr. Murphy, Roberts, Mr. Rogers, Dr. Small, Turman, Trescott, and you. If I did not call out your name, please send her a photo of yourself so that we can get a new badge made for you. I mean, I don't believe that you will be needing to go into the building anytime soon, but at some point, hopefully, you'll be able to do that, and we will have your badge ready.
Melanie, I think I sent my photo already.
Yes,
Did you
got
call
yours.
my name?
Yes.
Oh, okay, okay.
You're
Thank
good.
you.
You're good. Yes.
Melanie, are we going to have to break into the building to get our badges?
You will get your badge on the 26th when you come in. We'll have it for you. Okay, the other thing is, everybody for some reason this morning got an email perhaps saying that you have to take public disclosure training. That is something that I didn't know about, and Heather is looking into that. If you need public disclosure training, perhaps we could do it at a lunch and learn, and therefore you wouldn't have to do it. But I don't think I've ever received that. So we're looking into why that came out to everybody this morning. Number 3, in my report, you read that we have a new Secretary of Health, Dr. Shaw, who is an ED doc who is moving and has moved, I think, as of this week from Harris County, Texas. So he will take over from Dr. Wiesman to run the department. He seems to be very knowledgeable. And again, he's a former ED physician. And lastly, I want to put in a plug for our Health Disparities Work Group. Our own Dr. Curry is presenting on behalf of our commission at the symposium that is put on by the Federation of State Medical Boards on January 26th. So you can watch it. Obviously, it's going to be a webinar. She will be providing some information on what we are doing regarding implicit bias and health disparities. So I just want to give a plug out for that. That's it.
That's great, thank you. Other staff updates, revisions, new information?
It doesn't look like there's any hands raised, so.
Okay, thank you.
I have a question for Melanie. Have we learned anything this year with this kind of meeting formatting? Do you think when we can meet again that there'll be some changes in the structure of how we get together and how often?
I don't think the frequency will change because we have our calendar set 2 years in advance. I think that we can, and it depends on what you all want to do. You can do some in person and some virtual going forward if you so desire. I miss the in-person meetings. I think that you get a lot done.
Yeah, I do too.
And you get to network and get to know your fellow commissioners. The staff gets to work with you on other issues offline and at lunchtime. So it will be up to the commission to determine whether or not you want to go back to the exact way it was before we went virtual, or if you want to intersperse some virtual meetings. I think that the workshops for rules works really well in a virtual atmosphere. But so it's one of those things you guys can discuss going forward.
Thank you. I think we all enjoy meeting in person rather than being virtual, but maybe moving forward, there's a combination that we can address. So a combination approach. Other comments? Okay, let's move on to the AAG report. Heather?
Nothing further, just I was going to do the lobbying reminder, but I did that earlier in the meeting, so nothing further.
Anything in general anybody wants to mention, bring up at this point in time before we adjourn? And the meeting is officially adjourned. Thank you all.